Hello again and good afternoon. Thank you for joining us. My name is Annalise Fisher, and it's my pleasure to welcome you on behalf of the Ohio Program for Campus Safety and Mental Health to today's webinar, Clinical High Risk for Psychosis, Considerations for Colleges and Universities. Before the presenters are introduced today, I do have a few brief announcements to share. CME and CEU credits are available. The activity code for today's session is 65 CROC, that's CROC, and this code will expire on Wednesday, March 5th at noon. Please be on the lookout for information periodically posted via the chat function regarding how to obtain CME and CEUs. Please join us for the next OPCSMH webinar in April. We will be joined by our partners and colleagues for a roundtable discussion titled Stronger Together, Mental Health and Suicide Prevention on Ohio Campuses, focused on the current state of affairs in student mental health and suicide prevention programming on Ohio's college campuses. Additional details are to come, but you don't want to miss out on this very important talk. Additionally, we encourage you to secure your spot for the upcoming OPCSMH 7th Biannual Conference that will be on May 15th, 2025 in Dublin, Ohio. Registration for that opens today. You may find additional details regarding upcoming events on our website and social media. Feel free to like and subscribe to our social media channels. Additionally, today's webinar will be recorded and the slides will be disseminated following the presentation. We encourage you to post questions and comments in the Q&A or chat function during today's presentation, and we hope you will engage in the discussion. So I will pass things off to Jessica to introduce our lovely presenters for today.
Thank you so much, Annalise. My name is Jessica Zabala, and I am Director of the Ohio Program for Campus Safety and Mental Health. And now to briefly introduce our presenters from our sister coordinating center of excellence, the BEST Center of Best Practices in Schizophrenia Treatment. I have the pleasure of welcoming Dr. Harry Civic. Dr. Civic is a clinical psychologist with experience working with individuals who experience severe and persistent mental illness. He provides training and consultation in cognitive behavioral health therapy for psychosis or CBTP to community agencies. Dr. Civic is also clinical associate professor in the Department of Psychiatry here at Neomed. And next we have Dr. Danelle Hupp. Dr. Hupp is a clinical psychologist who has expertise in the treatment of serious mental illness, including extensive training in family psychoeducation and other family-based services. She is the senior consultant and trainer for family-based services here at the BEST Center at Neomed. And finally, we are very, very excited to have with us Dr. Deb Rhoda. Dr. Rhoda is passionate and committed to helping people live their best lives. She is the Director of Practice, Implementation, and Evaluation, also here at Neomed. And so without further ado, we are very excited to have with us for today's presentation, Drs. Civic, Hupp, and Rhoda. I turn it over to you all.
Thank you so much, Jessica. Really appreciate that warm welcome. And on behalf of Danelle and Deb and I are very grateful to be invited here to be a part of this program, be able to speak with you a little bit today. So very excited about this. It is a team effort, so I'll begin the speaking and then hand it on to Danelle from here, and she will also advance the slides, which I appreciate. So today we're going to talk about clinical high risk for psychosis, particularly as it relates to colleges and universities. And to warm up the chat box, if you're familiar with clinical high risk for psychosis, if you could just put a little note in the chat box like I am or me too or something like that, that we can kind of see who's there, and then how many folks have some awareness of clinical high risk. We'll go on to the next slide, Danelle, while I'm doing some of the other introductory things. So our objectives today is to describe clinical high risk for psychosis, what it is, what does this category mean, what does this description mean, discuss the role that colleges and universities may play in the early identification and support in this situation, and then to identify some sources of partnership, referral, and we also have a fair amount of resources that we'll provide near the end of the presentation as well. Next slide. So who we are the Best Center, and Jessica kind of introduced that a little bit. Best Practices in Schizophrenia Treatment is located at NeoMed. We're one of the centers of excellence along with the Ohio Program for Campus Safety and Mental Health. So we all work in that same space. Our mission is particularly focused on improving as many lives as possible for individuals who experience psychosis, schizophrenia, spectrum disorders, other kinds of conditions, and their loved ones. So we include family supports. We try to be rather systemic in our approach. And we do this by accelerating the adoption of evidence-based and promising practices. So we try to get out there, do training, technical assistance, providing expert consultation to community mental health centers, hospitals, other places like that. And we've been operating since 2009, starting with our first episode for Psychosis program. Next slide. So the Best Center and CHRP, or CHIRP, sometimes we refer to it affectionately, so clinical high risk for psychosis. So in 2018, SAMHSA had put out a sponsorship of funding for programs to develop interventions for clinical high risk for psychosis. So it was a 4-year grant. And the Best Center was involved in the first wave of this. We were providing technical assistance to one of the local community agencies. They were one of 21 national sites to be funded to develop this kind of programming. The grantee is located in an urban setting. As I said, mental health agency. We had also worked with this agency in the past related to first episode psychosis programming, and they've been involved with that for about 15 years. So it was a natural kind of next step for them if you think about the continuum of interventions from before psychosis to early psychosis kind of interventions. The other thing I'll add is that as part of this grant, we did technical assistance locally, but then afterwards we did some interviews and surveying of other national sites to kind of learn a little bit more about like challenges and facilitators in the space. So we were very fortunate to be able to talk to many other programs throughout the country related to this. So that informs a little bit what we're going to speak about today. So let me move on to what is clinical high risk for psychosis. So this term, I don't want to say became popularized, but in the 90s, really in Australia and Europe initially, there was discussion among researchers and therapists around clinical high risk for psychosis. And this kind of came from the idea that we know that individuals who develop schizophrenia, there's a period of time before the full onset of symptoms where things are different. And this is referred to as kind of the pre-psychosis phase, sometimes referred to as prodromal. Individuals experience some distress, but not enough that really gets to full psychosis. So what the question became was, could early intervention be helpful during this phase? Want to go to the next slide then? So this leads up to our next big graphic here. So if we can identify those who are at clinical high risk, provide an intervention, could we then either full out prevent onset of psychosis for individuals or delay the onset of psychosis, which we'd be considering better outcomes? And even if we delay onset and a person eventually develops more full threshold psychotic symptoms, they would be connected with services earlier too, which also turns out to be a very helpful thing. Next slide. So how do we think about risk states? Mostly everybody has a sense that the risk for developing psychosis, the incidence is about 1% in the general population, right? So what researchers and therapists went about doing is trying to identify who would fall in this higher risk group. And we found that there does indeed appear to be a higher risk for individuals when certain subclinical symptoms and other risk factors are present. And I'm going to kind of give you just a little description of some of these categories. And this comes from one of the assessment tools that's used, the SIPS, the Structured Interview for Psychotic Symptoms. We'll talk about that a little bit later. But they identify 3 at-risk groups. One is attenuated positive symptom psychosis risk, so a mouthful there. And that one, this category is individuals who show attenuated symptoms, right? Just what the term says. So for instance, many are familiar with hallucinations, both visual and auditory are very common with schizophrenia. An attenuated version of that would be maybe hearing murmuring or seeing shadows. So it's attenuated, it's not full threshold. So the intensity isn't quite as high. The other piece is that the frequency usually isn't as much. So it's less intense, less frequent would be part of the attenuated part. And then the third factor is insight. What happens often with individuals who develop schizophrenia is that they lose the awareness that what their experience is connected to mental illness or some state that's happening. At the attenuated level, people may have these experiences, but maintain that sense of, okay, something's off, and my mind may be playing tricks on me. So there's some insight about it as well. So when those constellations of risk factors come together, we call that attenuated risk, and that represents the highest percentage of this risk category, and that's about 85% fall into this category. Brief intermittent psychotic symptom psychosis risk, or BIPS, which is more fun to say, is really what it says also. It's brief, but full threshold psychosis. So a person may experience a full threshold experience of psychosis, suspicion, paranoia, or maybe hearing voices, but the frequency is much less. It abates usually within a week or a shorter amount of time, so it doesn't have the full time period that goes with psychosis and the other factors, and that accounts for about 10% of the individuals fall into that category. And then the third category is referred to as genetic risk and deterioration. So this really comes from the awareness that there is a biological risk for schizophrenia, genetic risk. So if you have a parent or sibling with schizophrenia, first-degree relative, your risk tends to be higher. And so with those individuals, we're looking at, according to the scale, deterioration in functioning of about 30% on the GAF, or the Global Assessment of Functioning. So they have ways to kind of measure that. But essentially, family risk factor, and then you see a decrease in functioning from where they were functioning before. So those are our states. We can go on to the next one. So how do we define better outcomes? Part of the way we define it is, can we reduce transition to psychosis? So based on modeling and estimates, individuals without treatment who fall into one of these categories estimated that their transition to psychosis could be as high as 35 to 50+% within that first year. If you look at the graph below, with treatment, so this is looking at meta-analyses and other treatment studies in the early 2000s, you can see the transition from high risk to psychosis after 1 year is 22%. You can see it goes up with each year, but less than the first category. And then if you go to the right, the column there, transition from high risk to psychosis in more current studies. So this is a 2024 study. After 1 year is about 15%, 2 years, 20%, and then 25 to 30 after 4 years. Next slide. So you can see based on that over time, it seems like the conversion rate is decreasing to some extent. Now we hope and we think that this may be due to greater access to intervention and better and earlier identification. It's difficult to prove this, but we're hoping that trend reflects that. The other bit of evidence we have in terms of just outcomes is there have been a number of studies that have used targeted interventions, for example, cognitive behavioral therapy for psychosis, CBTP, where they would take a sample of individuals at risk, provide CBT intervention for one group, another group maybe get treatment as usual, and finding an association for individuals who get targeted interventions, reducing the risk of transition at 1 to 2 years. Well, this early identification intervention seems warranted, but also those who transition, we want to kind of keep services going for them over several years. Go on to the next. This graph just kind of visually represents what I was just describing. Looking to the left of the graph, the CHRP zone, that's where we're looking to identify individuals. Hopefully the trajectory, we can kind of keep it on an upward trajectory. You can see where the psychotic phase occurs, so that would be first episode psychosis. Then you can see the variable outcomes from there. Next slide. So identify groups. Next slide. So, so why the college years? Why would we focus there? Well, for one thing, we know that psychosis tends to occur in late teens and early adult years. We also, as I was mentioning earlier, know that individuals who develop psychosis, there's usually a couple of years where there are some signs earlier on that we can target and identify folks who could be at risk. So where is the location? Where's the place where we have young adults? A very large sampling of young adults, that would be college campuses. Half of the individuals in the US, 18 to 24, attend college, university, community college, some version of that. So college settings host the largest groups of individuals who fall in the age range where this risk categories would likely to present themselves. Next slide. The other thing that we think about when we think about college we think about factors contributing to risk during that time zone. So I've already mentioned that it's a common age for psychosis to appear. But we also have when we talk about schizophrenia, one of the very common models is something we call stress vulnerability model. So psychosis occurs, schizophrenia develops when there's an interaction between a person's vulnerability, typically biological, and then certain stressors that hit, and then the expression of it sometimes is in psychosis or schizophrenia. Vulnerability is often thought of in terms of biological or genetic vulnerability, but we also talk about early traumatic experiences as creating a kind of vulnerability. We know that individuals who have singular and then multiple traumas are at greater risk for developing psychosis. So that's another kind of vulnerability. And then we enter college, right? So college is a great and wonderful thing, great adventure, but it's also a time of a lot of stress, right? So there's new experiences, first romances, exploring identity, sexuality, maybe have more routine, maybe less routine than they had before, supervision, less supervision, leaving home. There's a lot of things that press on certain kinds of vulnerabilities during that time period. The other factor that I'm going to talk about just briefly before I hand it on is the relation between substance use and psychosis. We know that, again, college is a great time period, but there's also a fair amount of substance use that happens in college campuses. In particular, we know from the literature that there's a strong cannabis to psychosis association. We know that marijuana is one of the top 3 substances used by college-age students. And there's a great deal of research that's been released in the last really decade looking at use of cannabis during the teen years as being associated with increased risk of developing a psychotic disorder. And more than that, we know that this relationship tends to be dose related. So greater frequency of use with higher potency cannabis, all of those increase the risk of developing psychosis. Again, it doesn't guarantee it, but using cannabis at a younger age with high frequency and higher potencies, especially if it's interacting, again, think about vulnerabilities, is something to think about as we think about where psychosis can occur. So combined with other risk factors, the long and short of it is we want to kind of factor in substance use as part of that. So the next thing we're going to go on to is what signs can we look for? I mentioned some stuff initially, but Danelle's going to take it over from here and kind of guide us from there. On you, Danelle.
Thanks, Harry. All right. Hi, everyone. So when we're thinking about clinical high risk for psychosis, it's important to be able to identify or at least have some awareness about what it might look like. And so, the early warning signs of CHIRP really are non-specific. So it could be due to a number of things, feeling like something's off or not quite right, feeling a little bit confused, having difficulty concentrating or communicating, your schoolwork or relationships or your ability to, function at your job is starting to slip a little bit. You're not maybe quite as interested in hobbies or activities that you were before. So these are some of the things that, might be experienced or observed sometimes even before the individual is seeking mental health treatment or enters the mental health system in some way. So they're starting to have these experiences, these noticing some things are not quite right. But you can't really pinpoint that it's a clinical high risk for psychosis because somebody might be experiencing some depression or some anxiety. And so this is what makes it tricky to identify individuals at clinical high risk for psychosis because these things are so nonspecific. And so something to think about is as you're looking at these early warning signs is, how many of the early warning signs, and there's another slide that includes some additional ones, but how many are occurring? How frequently are they occurring? How severe are they? And how much are they interfering with that person's daily life? So those are some of the things that if we're starting to notice, it's not just one or two of these things. I'm starting to see all of a sudden self-care is slipping and they're sleeping all day or they're not sleeping and they're up all night, which is different for that person. Feeling a little uneasy, making some odd statements. And so how often, how much are these things, contributing to or impacting how the individual is functioning or experiencing their day-to-day lives. So oftentimes with clinical high risk, we know that they present for services for other concerns that they're experiencing. Oftentimes they will be presenting at campus counseling centers for things like anxiety or depressive disorders, or they're struggling socially or having trouble engaging with their peers. So we do know that more than 70% of those at clinical high risk for psychosis have at least one diagnosable disorder. And, often they have 2 to 3 comorbid or co-occurring disorders. And typically they will present first for anxiety, depression, and sometimes social phobias. So there are a number of screening tools that don't allow you to diagnose an individual. It just gets you, if your ears have been perked up by something that somebody says or some concerns that you have, they just give us more information if this is something that we may want to look into more. So, have some further assessment or follow up. So something, if you want to include in the chat, that I think it's helpful from our side of things to know in, campus university settings, what are some of the symptoms that you're routinely screening for already when individuals come through the counseling center? And what type of screening measures does the center use typically for these symptoms? So in a university counseling center, not only is psychosis risk screening warranted, it's pretty crucial, and it's actually for a larger proportion of students seeking mental health services than we might expect. So, in one study that looked at a particular screening tool that we'll talk about, it identified a fourth of help-seeking students they screen positive for being at clinical high risk. And so, a relatively large proportion of your student population that present to the clinic, the mental health center on campus, may be experiencing distress or interference or some kind of disruption to their daily lives because of these sort of sub-threshold psychosis-like experiences. And so, is this an opportunity or a time to maybe cast a wider net with your screening? So considering, making a brief screening tool for psychosis symptoms, a self-report, for example, more routine as part of maybe your intake process. And we'll talk about that more in a minute. So, there is a simple screener that has been, used in studies that really it's just asking 2 items. And this will kind of give you an inclination if you think that the individual should seek, further assessment or maybe services outside of the campus counseling center setting. And this particular screener was used in a college counseling center. So we know that it wasn't, too taxing on the counseling center, given sometimes limited time frames that providers have in this setting. So the one question that they ask everyone is, do you see things that others can't or don't see? And then for the second question, you have options. Most often, they were finding that, have you ever felt that someone was playing with your mind? Was the question used most often. They found most evidence supporting that. But you could also ask, do you hear the voice of someone talking that other people can't hear? Do familiar surroundings sometimes seem unreal to you? Or have you seen things that other people can't or don't seem to see? So that can capture a bit of that past. And so if you want just a very simple screener, if you, as part of your routine screening, or if you want to implement a simple screen when you might have suspicion that something more is going on, this is an option. There are a couple of common screening tools that are available readily, and further down in our slides, we have links to them so that you're able to access them. So there's the Prime screen, which is just a 12-item self-report. This one has also been studied in a university counseling center setting. And it demonstrated that it was not only useful in identifying individuals, but also that it was feasible in the time that you often have with individuals. And then there's also the brief version of the prodromal questionnaire. This is a 21 self-report instrument, and this one, both either could be incorporated more routinely, either at intake or during your screening process. So again, we have those linked. You can use them freely. It has scoring information and how to use the tools. So thinking of screening as an intervention to a pathway to intervention. So just and Harry did a nice summary of this as well. So if you're trying to decide between psychosis or sort of subthreshold things, clinical high risk that are going on. So generally speaking, if somebody has absolute conviction about a belief or idea, there's nothing you could ever say or do that would make them think otherwise. They know this fact to be true. That more than likely is going to be psychosis. If an individual is experiencing distress because of some of these psychosis like subthreshold things that are happening, they're feeling a little off, they know they have awareness that something um, is happening with them, but they are not convinced of this idea or that experience, you're able to kind of give them alternative explanations that seem reasonable. They also maintain that level of awareness or insight that something is off or something's not quite right. That tends to be more likely clinical high risk. So just for you, as you think about this moving forward. So there we go, screening to intervention pathways. So positive screening would lead to a referral for a more thorough evaluation, and there are standardized measures out there that are available to identify risk status. The most commonly used is the one Harry mentioned earlier, the Structured Interview of Psychosis Risk Syndromes Scale, the SIPS, but this one does have requirements. It requires training for a fee, and you have to become certified to use it. And it's a 2-day training. And so oftentimes this isn't going to be something necessarily feasible for a campus community, especially if you don't provide full psychosis services, but it is out there for agencies and things like that to be able to use. But realistically, early intervention and catching those at clinical high risk only has a chance to work when these individuals are first identified and then when appropriate referrals are made. So, early to screen, early to intervene. And that really is the goal, because the longer the duration of untreated psychosis, we want to keep that period as short as possible to have a more positive prognosis opportunity, and less interference with their life, with school, work, family, relationships. So the earlier we can intervene and keep a duration of untreated psychosis, the better. And so if we can catch individuals at clinical high risk, we're ahead of the game. So strategies for helping individuals. What can we be doing? Treatment really is, and prevention is really powerful. When we have the opportunity to reduce or prevent that untreated duration of untreated psychosis. We know from the literature that some targeted psychosocial interventions, such as cognitive behavioral therapy for psychosis, they really can reduce the frequency of conversion to full psychosis, full threshold psychosis, or delay the onset of those symptoms, but both with better outcomes. And there's been a lot of work done internationally, actually, before it came to the United States. And it really is emphasized that, tailored therapy is important to that individual, a thorough assessment, making sure that they have sort of this care or case management to support them, and that emphasis on the close involvement of family, loved ones, whomever is in that individual's support system. We know that sort of system wraparound and system collaboration is key for these young individuals because they're facing and interacting with so many different systems. So we have to coordinate. So thinking about school, college, faith-based organizations, law enforcement, if there's been any intersection with the criminal justice system, primary care, insurance, like, with Ohio Rise through Medicaid. So all of these systems working together to support these young individuals. And so where in this landscape do colleges and universities fit within the system of care? And so, these next slides that'll take us through close to the end is, if you are a college and university staff person, administrator, faculty, things that we can do to plan ahead to support these students. Increasing awareness. Increase awareness of CHIRP and early psychosis. So if we can hold, awareness raising and anti-stigma campaigns that educates not only students, but also family members and, all campus staff about early psychosis and clinical high risk, and also how to get help. So if it's for yourself, for your child, for a friend, for a loved one. So what are the steps these individuals can take? And we have that in later slides. Highlighting the importance of a prompt referral either to a counseling center on campus or a local mental health agency, and really building up, the local community's knowledge and response to these young people at clinical high risk. And so if there's a strong faith-based organization within the community that many of your students attend, working with those individuals to make sure that they have some level of awareness of what these early warning signs are. Providing training opportunities is another proactive way for campus and universities to get involved. So ensuring staff are trained in what to look for and what to do, not limited to, but ensuring obviously student counseling centers have this information and training. The student health center, because if they're presenting to, a PCP, initially, resident advisors, faith leaders, faculty. So those individuals that might be the first to see or the first that the individual seeks out for help or support. And also familiarizing your clinical staff, so those that are working in the at least the counseling center on campus, with those brief screening tools so that you can utilize them, and thinking through, could this be a part of our routine assessment or intake process. Developing psychosis literacy for staff at the university. So what is CHIRP? And early psychosis? What are some of those early warning signs? How can they access psychosis specific services? And getting comfortable and feeling confident in knowing how to be of assistance. So knowing what supports and resources are available to you, knowing where to make a referral. Those are really, really important. And the faster, the better. University counseling centers, we encourage you to think about developing an internal screening process. So figuring out if you want to use a screener, when you might implement it, who you might screen for. And so is this your health center and the counseling center, or maybe just the counseling center? Is it part of the routine universal screening that you do at intake, or is it only case specific or when it's indicated, which might be family history or certain symptoms that are induced? So, I would say, our stance is integration of, brief screening tools into more of a routine practice. Since we know that it can be a quarter of your students that are coming into the student counseling center that are seeking help for what ultimately ends up to be clinical high risk. Facilitating connections to those services, again, so coordinating care, not only internally, like with student support services, if they need accommodations, additional assistance with accessibility, but also externally, which will follow up. Deb will talk about in just a moment. But the more knowledgeable and prepared our systems are, so including everyone within the campus and university setting, the shorter the pathway to appropriate care. So they have less, touch points. So they're not going to the PCP, followed up by the student counseling center, followed by the campus mental health center, and then a different referral, that we're able to get them more quickly into appropriate services, which is really critical for those at clinical high risk for psychosis. And oftentimes, campus mental health providers aren't going to be their first stop on their journey to find appropriate supports and care. Sometimes it will be, faith-based community, resident advisors, and typically if the mental health provider isn't the student's initial contact, this could mean a couple of things. One, that they are a little less trustful or a little iffy about the mental health system, or they might be having more negative thoughts about themselves. So, for example, shame in feeling like they need mental health care. So connection to services internally, and then I'm going to pass it off to Deb to talk about connections and building those connections within your local community. So Deb.
Absolutely. Thank you. And thank you everyone for coming and really thinking about this with us. Depending on your setting, you may have extensive internal resources, you may have limited internal resources. And so it's always important to build your internal resources and your external resources. There's a lot of different things that might already exist at your local college or university, and some that you might want to bring onto your campus. So NAMI, which is the National Alliance on Mental Illness, has NAMI on campus, as well as a whole college guide for students. There's other organizations that are student run. So Students with Psychosis, the Cure SC Foundation has some campus clubs. There's Active Minds, JED Foundation. There's a lot of these different things that if you don't already have it on your campus, that you could bring to your campus or that might exist in your local community. Next slide. Identifying what partners do already exist in your community are going to be important. There are what are known as coordinated specialty care for first episode psychosis services, and that's the QR code that you see there. They don't necessarily specialize in this CHIRP realm. They focus more once the person has developed that psychosis. However, they're housed within community mental health organizations. So they will have the expertise, or they may know how we can help support individuals that might be in that CHIRP space. Coordinating that care while they're in school is going to be critical. If someone does choose to leave school for a period of time and return, again, we want to make sure that we're coordinating and we're helping wrap that person. Danelle had the resource, and it's also in our resource list. There's a publication that has a lot of different accommodations and ways that we can help students be successful while they're on campus. And making those referrals to the external services as soon as we find them and when they're appropriate is, again, going to help reduce or eliminate some of those other challenges that people might face moving forward. We want to make sure that you're finding those additional resources. We can kind of help connect you or come up with ways to train your local folks. You want to get comfortable with that language. You want to make sure that you're helping that individual feel comfortable, discuss whatever they need to discuss with you. And a lot of times the word psychosis can feel scary. So even just talking in that high risk range and just the unusual experiences, things like that. Next slide. We want to make sure that you're asking about those experiences throughout your work with an individual. So especially when someone is building rapport or getting to know someone, they've been exposed to all of the stigmatizing media portrayals of people having those unusual experiences. It's not going to be the first thing that they're going to volunteer. So that's where we were saying before, it might be more that depression, it might be more the anxiety, it might not even be the individual expressing this, it might be a professor notices some strangeness, changes in someone's writing style. It might be that the RA is seeing the person kind of changing their clothes or talking some strange things. So we want to make sure that we're comfortable and we're engaging people and helping them find that space that we can really kind of see what needs to happen and help either get them to the right internal or external resource. Next slide. We also want to make sure that we're strengthening those protective factors. A lot of times, we can talk about the symptoms and the challenges people are facing. There are things that actually can help protect someone from going on and either developing psychosis fully or having worse outcomes from that. And so one of the things that we do see is people who meet that criteria for that CHIRP do rate lower on self-esteem, social support, and resilience. So any kind of programming or supports that we can find that can really help build that self-esteem, help them stay in school or find the best support so that they can be successful, and really build those relationships or maintain those relationships so they have that social support to help them be resilient. And also thinking about, what are some of the challenges? So we're saying that, depression, anxiety, the social issues are going to be there. And what can we do to really help connect people so that we can mitigate some of that and help support them? So if you do have that student that doesn't want to be referred to an external resource, think about what other options and opportunities might exist in your area. What relationships do you currently have? What can you build? What are those areas? What can you do? So I know some counseling and just university health services have a more full array they can offer. Some might be limited on the number of sessions. So really be intentional in communicating what you can and can't do. That might be the thing that can help bridge them to that external resource. Is unfortunately, we're only set up for 4 sessions. So that's why we partner with this community agency so that you can then get more full services or more supports. And then finally, what can you do if you're concerned? So not everyone who is going to be interacting with an individual is going to be in that health service situation. And so if you see that change in writing style, you see that change in maybe hygiene or how they're interacting with other students, what can you do? And that's, again, really identifying what are some of the resources that are there and how can we really help people engage with either internal or external resources. It's possible that your local community doesn't have this specialized chirp services. This is something that we're working to grow, and it's something that has been growing, but it is still limited in a lot of areas. So definitely working with whatever providers you can engage with. We mentioned before about the coordinated specialty care for first episode psychosis providers. They might also know of other things. Make these connections now before you have that student sitting in front of you so that you're not kind of fumbling around when you have that person. Start having these conversations, figure out what does exist, and talk with them about what they can and can't do. So that's, again, even generically, you might have a specific student you're thinking about, but you don't have to use their specific information or their name, but really finding out what resources exist and what are the options. If there isn't those services locally, become an advocate. Remember, the more we kind of recognize and bring to the awareness of those around us that this is an issue, the more likely that we are making that case to really bring those services into the local area. So keep making those referrals, talking to mental health boards, talking to your campus leadership about what services you can provide. There's a lot of different opportunities that we can advocate to bring those services at least to the local area, if not hopefully internally, that you can provide a lot more supports. There's a lot of different resources that we built in here. The slides are going to be available to you. So we strongly encourage you to look at this. These first 2 links are those toolkits, and that's where it has the list of ways that you can support students, and including some of the accommodations that can be specific to individuals who experience psychosis. I'm not going to go into all these resources, but we mentioned NAMI, Strong 365, SAMHSA, which is the Substance Abuse Mental Health Services Administration, established a National Training and Technical Assistance Center for Early Serious Mental Illness. So that includes this clinical high risk for psychosis, as well as non-psychosis related issues and that first episode psychosis. So there's a lot of great resources there and more coming soon. And here are those links that we talked about for the prime screen, the PQB. There's another WorkCap. So there's a lot of different screeners. We strongly encourage you to look within your electronic health records, see what questions might exist there, figure out ways that you can incorporate this into your work with people so that you're getting at this information and you can kind of help identify it as early as possible and guide people into the right supports. There's a mini version of the SIPs, and so that there's actually a free online training that you can kind of go through. There's also the CARMS, which is the Comprehensive Assessment for At-Risk Mental States. So again, there's a lot of different resources that might be available. We have some resources on our website, so you can go visit us there. And another resource that's available here from Neomed, we have the Ohio Systems of Care ECHO for youth involved with multiple systems. And so that might be another opportunity that you can bring a situation to that community, talk about some of the challenges and see what resources or recommendations you might get from that community. It's a nice collaboration between the Best Center at Neomed, as well as Center for Innovative Practices at Case Western Reserve University, the Ohio Colleges of Medicine, the GRC, Department of Developmental Disabilities and Medicaid, as well as Mental Health and Addiction Services. So you can learn more and register there. And finally, just really think about your current role and think about like what questions you have based on what we've all talked about here today, what you want to learn more about. Where do you see opportunities in your community, and how might this information that we shared today be applied for your local community? I'm going to stop us here so that we have some time to really get at some questions.
And Deb, I just want to first of all thank you as well as Dr. Civic and Dr. Hupp for that very informative presentation. And certainly want to encourage our folks who are on, if you have questions, to please feel free to type them in the Q&A and then also the chat function. So you can use either one of those options for questions. And we do already have a question that has been presented, and I'm happy to read that for you and then throw it out to whoever would like to respond. But the question is there any evidence for the role of medications in preventing progression to psychosis? And specifically, what about supplements? And then historically, there was some evidence that omega-3 fish oil had some positive benefit in reducing transition to psychosis. So, I don't know who would want to respond to that, but I'll put it out there.
I can take the first flush at it. So none of us are psychiatrists, so we can't speak too much to the medication piece. However, and you know, supplements, I'm not really too sure. I've heard the same about fish oil and other things with psychosis. Our medical director here, he's a psychiatrist and a pharmacologist, and he's always happy to answer questions. So if you send them our way through that Best Center at neomed.edu, I'm sure Dr. Messamore would be glad to respond to that piece of it. And medications, you know, I just have to say anecdotally, based on, you know, Harry mentioned that we talked with a number of different organizations and SAMHSA grantees during that first wave when we were engaged with them. And we had the opportunity to hear what others were doing and to learn from one another. And so for those individual programs, there were different approaches regarding medication and clinical high risk. Some were very much of the mindset of being open to medication early on as a way to prevent transition or potentially prevent transition as long as they were experiencing enough and severe enough of symptoms. Where others were much more, they were much more conservative in their approach and tended to use medication only and when it was really, really clinically indicated because symptoms were severe enough. Or there were enough of the symptoms. And typically when it crosses that line, you're into a first episode of psychosis, so full threshold psychosis. And so right now, from, you know, our personal experiences with teams, it's pretty varied what medication looks like. within the treatment plan. I don't know if
Yeah.
Harry or Deb.
Well, the only thing I appreciate Danelle's that, we are not doctors, we do not play one on TV. I will channel our medical director, though, Dr. Messamore, about the fish oil, and I have heard him speak to that the dose of fish oil that has been shown in just individual case studies to even maybe sort of have people would need, and I'm going to exaggerate, like an entire bottle a day. It's not the typical over-the-counter dose that you would just take for that. So I just wanted to kind of add that in there. I do see something that did pop up in the chat, though, and I'm going to read it so that the recording has it, and then I'd love to address it and invite others here too. Is it generally your recommendation that a student take a medical leave to pursue treatment when a first episode of psychosis appears? I'm aware that students can be resistant to that recommendation, wanting to persist at the university. And I would say that it is not necessarily the recommendation. It really needs to be individualized to how that individual is doing. However, one of the key components to the coordinated specialty care for someone experiencing that first episode is supported education. And anything that we can do to support that individual to stay on track with whatever it is they're doing. So that's where we talk about, are there accommodations? Are there some changes to a schedule that might help an individual? Are there things that can be used to structure either the coursework or the assignments to help them be successful? There's a lot of options and opportunities. So again, it's really seeing what that individual needs and can do. What are those supports that exist, and how can we help them be successful? For some individuals, they do want to take maybe a semester off while they can kind of get some of the other things under control. That stress vulnerability that Harry was talking about before kind of plays in there. For some people, it's more stressful to leave school than it is to go off and have that unstructured time and be in treatment or whatever that might look like. So it's really important that we work with the individual, we work with their support system to really figure out what it is they need. And I don't know if Danelle or Harry want something additional there.
No, I think that's great, Deb. I agree with everything that you said. And I would use it as an opportunity to also talk about one of the things when we talk about treatment for psychosis is really keeping the person's aspirations really forefront, right? So if school is really, really important, then we'll want to weigh that in consideration. And even if they do take a, leave of absence or whatever, we want them to know, we know this is important. We want to work with you to get back to that, right? So like getting at that value, getting at that aspiration is really a big part of helping people to recover when they do experience psychosis. I'll just add that little piece.
Wonderful. Thank you so much. And it looks like there is another question here in the chat, so I'll go ahead and read that out loud. The question is, what is a recommendation for a student who has regular crisis situations arise, but are not, oh, I'm sorry, the chat moved a little bit, arise related to psychosis, but are not following through with counseling center staff referrals? Community college setting, so disruption is present, but not quite at a level of code of conduct.
I can start with just a couple of ideas and then pass it on to Deb and Harry to add. So, as Harry was talking about, what matters to that student, what is meaningful to them, what do they value, and are their current circumstances in line with that? Could there be things that are happening that are interfering with these goals that are driven by things that are meaningful to them or that they value? Are there supports for this individual, and really thinking about how you think about the support system? So not necessarily just parents, but who else plays a significant role in this individual's life, and that's a significant role, meaning who has impact on the individual, who has some sort of power differential, who has influence, who really is a meaningful person in that individual's life, that they may be willing for you to reach out to. It could be a coach, it could be a grandma, it could be an RA. So that can look different for different people, but really exploring who are those people that matter to the individual and play a significant role in their lives that might be able to help and to assist in understanding what the needs are. Is there a faith leader who's involved that they would be open for you to chat with, and provide a release? Because this isn't uncommon in early psychosis that young folks are hesitant to engage in services or might go to one appointment and then shy away. Deb and Harry, do you have other initial thoughts?
No, I think those are the things I'd be thinking about, what's most important, and then just who are the other people in their life that we would kind of pull into the situation.
Yeah, clearly, at least the way this is worded, they're engaged with someone. So it's recognized that something's happening, that they're trying to refer them to the counseling center. So again, what can we do to really build on what motivates that individual? What are their values? Clearly they're staying in school, so they value that staying in school. And so how can we kind of help them see the connection or disconnection between maybe not having all the supports they need to be successful, and continuing in school? And that might also help motivate, and even just understanding why they haven't followed through, as the question asks, with that referral, and really getting a sense, because it could be a lot of, like I said, that stigma, and really kind of helping them think through what would be some good supports.
And just to add to that, because I agree, that what is the messaging? So, is it stigma? They're afraid of what peers might think, or is there a thought about mental illness or medication or something in their home environment if they're still, residing with family or parents, where they're put in this situation where they don't know, if mental illness isn't really an acceptable thing within their family system, how to address that when they're getting sort of mixed messages. Some are encouraging following through with mental health treatment, but that may be discouraged by others in their life. How do they balance and navigate that? Which we can't help them address that if we don't know what's going on. So
Excellent. Thank you. And we have time for just, I believe, one more question. And it's in the chat. Can you speak briefly to the role that hospitalization may play in an initial psychotic episode for a college student? Who would want to respond to that?
I could give some initial thoughts to it. I mean, it's one of those kinds of things, right, where it can be helpful depending upon how it's managed and the experience of it, right? It may be really essential part of stabilization and getting on the path towards recovery. Again, I think it's so important that keeping in mind also that there can be stigma and shame related to being in that kind of situation. And so delicately helping that transition post-hospitalization, to again, the goal being to get back into school. This does occur at times. It can be very challenging, and there are some benefits that can come with it as well. So I think kind of keeping both of those in mind, and so on the more negative side, if it doesn't go well, there can be a reaction in which there's a real pullback from treatment. If they have a medication effect that was particularly negative, which does sometimes happen, that we may need to work a little extra to engage the person who may have had that kind of maybe negative experience there. So those are my initial thoughts. Danelle, Deb, anything you want to add quickly?
just an opportunity to really wrap around the whole family system. I know I talk about the family piece a lot, but it is really important. So, do they understand why the individual was hospitalized? Are they ready for that person to be discharged? Do they know what to expect when that person is discharged? Do they have access to the resources? So, if you have had contact and have a release of information to speak with somebody that's part of that individual system, and that they're psychiatrically hospitalized, helping or reaching out to the hospital system if you have a release, or coordination of care. Oftentimes you can, but are you able to really connect with their system and help them be prepared and know what to expect? Would be another thing I would think about when somebody's hospitalized.
Well, that's excellent guidance and information to share. Thank you all so much for this excellent presentation. If you all in the chat would also join me in thanking Drs. Harry Civic, Dr. Deb Rhoda, and Dr. Danelle Hopp again for a wonderful presentation. These slides again will be disseminated as well as the recording uploaded to the Ohio Program for Campus Safety's YouTube channel. Um, Also, one last time, if you're claiming CME and CU credits, the code for today is 65CROC. That's 65CROC. Thank you again, everyone, for joining us. We hope to see you next month in April. Have a wonderful rest of your afternoon. Thank you again.
Thanks for having us.